Good evening, everyone, and welcome to this 22nd online teaching class under banner of Up-Aroi. This is our fifth class under this session. For this, I would like to invite Dr. Manisha Tandon. She is the consultant from the Nehru Memorial Hospital, Prayagraj, for moderation. Dr. Manisha, it is over to you. Please kindly start the session.
Okay. Good evening, respected all. I am Dr. Manisha Tandon from Kamla Nehru Regional Institute as a radiation oncologist. I want to give sincere thanks to Dr. Shaleen, Dr. Surabhi, and Dr. Ashutosh sir to give me this opportunity to moderate this session. And I want to, it's an honor to introduce to all Dr.Sphalta Baghmar, Senior Consultant Medical Oncologist in Mixed Super Speciality Hospital, Vaishali and Noida. And today she is talking about biomolecules in metastatic breast cancer, which is a very important topic. And I finished my DNB in 2008. That time, if a breast cancer patient in a metastatic stage, it was very difficult to manage. And we thought it's just a matter of 6 months or 1 year, and without any quality of life. But now I'm seeing with my patients on trastuzumab or lepetinib, they're doing very well with a very good quality of life. So it will be a very important topic or a very useful topic for our students. So I request Dr. Sphalta, please start your lecture.
Thank you, everyone. Thank you for inviting me, and especially Dr. Rashi, who has invited me for this lecture. She asked me for the biomolecules, and it is such a huge topic. Now each and every day we are getting such a tongue twister molecule, and in the morning when I open my email and a new drug comes up and I'm just able to pronounce it, and that is my task for that day. So but yes, the prognosis is now, like even in metastatic breast cancer, we are saying it's 4, 5 years, 6 years down the lane. Even with the patients who are having brain metastasis, second line, third line, we have drugs, and it is 2, 3 years, 4 years for them as well. So let me start. So targeted therapies in metastatic breast cancer. What are targeted therapies actually? So targeted therapies, because in cancer what we have, there are many receptors or in the plasma membrane or the cell membrane or on the nucleus. So these are, and there are multiple specific genes that because of that the cell is growing, and which causes the survival of cancer cells. When we target these specific genes or proteins, this is called as targeted therapy. So what are the targeted therapies in breast cancer? Like HER2 overexpressing tumor, then we have trastuzumab, lepetinib, TDM1, pertuzumab, margetuximab. Triple negative, we have platinum compounds, PARP inhibitors, anti-EGFR therapies. PTEN loss, anti-PIK3 beta agent is there. As such, it is in clinical trial. We don't have a drug available right now. Then PIK3 mutant, then anti-PIK3, anti-AKT, mTOR. So you name it. Like when we were doing DM, we had so many pathways. We have to learn all those pathways, and I used to think why we are learning so much of so many pathways when it is of no use. But now we know that each and every the element of the pathway, we have drugs against it. So, or we are in the process of making drug against these elements of the pathway which are causing the survival of the cancer patients now. So hormone positive, just a minute, hormone positive, tamoxifen, AIs, fulvestrant, these are acting on receptors or inhibiting the activity of ER. So they are also a targeted therapy. BRCA mutant, then PARP inhibitor is there. So what are the new targeted therapies? We will go through all these targeted therapies separately, like CDK4/6 inhibitors, abemaciclib, palbociclib, ribociclib, which is there for hormone positive breast cancers. PIK3 inhibitors, alpelisib, which is in PIK3 negative tumors, PIK3 mutated tumors, which has hormone positive and HER2 breast cancers, HER2 negative breast cancers. PARP inhibitor, we have olaparib, talazoparib, niraparib, rucaparib, and these are BRCA mutant breast cancer patients. TKIs, tucatinib, lapatinib, and then advanced HER2 positive breast cancers. Immune checkpoint inhibitors. Atezolizumab, though it is not used now, the company has taken back its indication in breast cancer, but immune checkpoint inhibitors, pembrolizumab is used now. Antibody drug conjugate, edotrans, that is TDM1, then famtrastuzumab deruxtecan, then secukinumab govitecan. So these are the drugs which have come up in triple negative breast cancers and HER2 positive breast cancer. So this is a drug which is used in triple negative breast cancer as well as in HER2 positive breast cancer. Other two drugs are used in HER2 positive breast cancers. Coming to, this is a cartoon which is showing a complex mechanism of action, and when you look onto this cartoon, you will be able to understand like what is HER2. HER2 is from the family of EGFR. EGFR actually is HER1. HER2 is in breast cancer. HER3, HER4 is in breast cancer. So what is the role of trastuzumab or TDM1? It is anti-HER2. What is the role of pertuzumab? It inhibits the dimerization of HER2 and HER3. What is lapatinib? This is a TKI. What it does? It inhibits HER1 as well as HER2. Like when this pathway HER2 is activated, what it does? It activates the downstream signaling pathway, that is PIK3 AKT mTOR pathway. So we have mTOR inhibitor. We have PIK3. If mutation is there, then in that case anti-PIK3. And now in ER positive patients, so aromatase inhibitors, exemestane, letrozole, what it do? They inhibit the formation of estrogen. Okay, that is made from with the help of steroidogenesis. What is the role of tamoxifen or fulvestrant? They inhibit this receptor estrogen combination. Now when all this process, downstream signaling pathway and everything, they go into nucleus, so there is the role of CDK4/6 inhibitor, which actually controls the cell cycle. Then PARP inhibitors, which is there for the DNA repair. So we will go through all these pathways separately, all these drugs separately, and it is a huge lecture. So whenever you feel like that is too much, then in that case we can certainly stop. So what are the limitations? We have targeted therapies, but what are the limitations of these targeted therapies? First limitation is the cancer cells become resistant to them. And what are the two ways? Either the target itself changes through mutation, so that the target therapy no longer interacts well with it. Now, tumor finds new pathway to achieve tumor growth. That does not depend on the target. So what is the solution for this? What we can do? We can, using two therapies that target different pathways of the cell signaling pathway, slow the development of resistance. So what we can do is we can use two targeted therapies, so at different point, so that even if one target become resistant, then it will be working through the other downstream signaling pathway. Another approach is combine this targeted therapies with a conventional chemotherapy, like we combine trastuzumab with docetaxel. Second is drugs for second limitation of targeted therapies are the drugs for some identified targets are difficult to develop because the targeted structures or the way its function is very complicated. Like RAS, you have seen RAS mutation in many of the cancers. In fact, 1/4 of the cancers they have this mutation, but still we have not come up with the drug. In fact, recently a drug has come up, but yes, we are not using drug targeting RAS mutation. Now, side effects as such, all the targeted therapies, they have their separate unique side effect, but in general usually these targeted therapies, especially TKIs, they cause diarrhea, they cause hepatitis. There is some skin problems like rashes, nail changes, then there are pigmentation. Then there are problem with the blood clotting, high blood pressure, and there can be a gastrointestinal perforation as well. So targeted therapies, coming to targeted therapies in hormone positive breast cancer. Uh, CDK4/6 inhibitors. Now, what you know about tamoxifen, you must have read tamoxifen, you must have read about AIs. Now, the newer thing is CDK4/6 inhibitors. Uh, if you go through the cell cycle, you will know that CDK4 and 6, they bind to cyclin D, and this complex results in phosphorylation of RBG. Now, after this phosphorylation, there is activation of E2F, that is elongation factor, and this leads to cell cycle progression. This CDK4 is the pivotal driver of breast cancer progression. So anything which inhibits CDK4 and 6, it will inhibit breast cancer progression. So we have drugs ribociclib, abemaciclib and palbociclib. These are the drugs which inhibit CDK4 and 6. But then what is the difference between the three drugs? So studies have shown, the in vitro studies, the clinical studies, they have shown that ribociclib acts best. It has like 8 times better activity than palbociclib, and abemaciclib is also better than palbociclib. And in fact, the free drug concentration achieved by ribociclib is like almost 22 times better than the other two drugs. So theoretically, yes, ribociclib should be better than the other two CDK4/6 inhibitor. But then in the clinical trial, what we have seen is that whenever this is Paloma 2 trial which evaluated palbociclib, Monarch trial which evaluated abemaciclib, Mona Lisa trial which also evaluated ribociclib. Now Mona Lisa trial, it evaluated Mona Lisa 7, it evaluated pre and perimenopausal females, and here we can see the progression free survival. The progression free survival, you can see that the hazard ratio is 0.56 in all the drugs. That means clinically all the drugs have done the same work in progression free survival. Overall response rate is almost the same. Clinical benefit rate is also almost the same. But yes, ribociclib has as such shown overall survival. But why, we don't know why they have not come up with the overall survival of palbociclib. But ribociclib as such, when there are people who advocate ribociclib in all the patients, and they give that ribociclib is the only drug which has shown overall survival benefit, so we should use ribociclib. But what actually how we choose among the three drug? We choose among the three drug by seeing the side effect profile. Now neutropenia, you can see that palbociclib and ribociclib, they have almost similar neutropenias. Grade 3, grade 4 neutropenias, you can see grade 4 neutropenias are also there in 10% of the patient. Abemaciclib, in this scenario, it is little bit better than the other two drugs. Now ribociclib, what it does is the QT prolongation. So whenever a patient who comes to us with some cardiac problem, who has arrhythmias, who is having pacemakers or something like that, we don't advise ribociclib. In that case, these are the two drug of choice. If a premenopausal female will come, we know that we have a data on ribociclib. So in a pre or perimenopausal female, will advise ribociclib. Now diarrhea. So diarrhea, you can see that the patients, the abemaciclib, you can see that how 80% of the patients, they have diarrhea. Grade 3 diarrhea is there in 10% of the patients. So this is how we decide about it. Palbase and ribociclib, these are the two drugs which is having almost similar GI side effects. But yes, ribociclib is a very difficult drug when it comes to the terms of diarrhea. Now liver enzymes is also raised in abemaciclib. Now these are the different side effect profile. Fatigue, it is almost same in all the three drugs. Monitoring, Monitoring is another factor because of which we decide which drug to use. Like palbociclib, it is just CBC. First two cycle, it is 2 weekly, and then it is to start at the beginning of the cycle, and it is up to 6 cycle. If the patient is tolerating well and TLC is not decreasing, the patient is not having so much of neutropenia, in that case you only do CBC whenever it is clinically indicated. Otherwise you don't have to do any monitoring. Well, you can see the monitoring of ribociclib. So if you see a patient whom you think that the patient will not be able to take care of herself, or and will not be able to come up with all this ECG, serum electrolytes every time to you, in that case we don't advise ribociclib. Abemaciclib, yes, it causes diarrhea, and we have to see CBCs and LFTs in these patients. So this is the way, different type of monitoring in all the three drugs. Coming to triple negative breast cancer. So how does this triple negative breast cancer mean? Then the thing that comes into your mind is BRCA1, BRCA2, PARP inhibitors. So let us just discuss about the basic of this BRCA1, BRCA2 and PARP inhibitors. So as you know that our DNA is constantly being damaged. What then happens? The cell cycle arrest is there, the DNA repair happens. If the DNA repair is perfect, the cell cycle restarts. If the DNA repair fails, the replication collapses and cell dies. If the DNA repair is imperfect, this is the time when it can promote a carcinogenesis. So if there is single strand damage, then we know about MMR, which is mismatch repair, and we have already seen MSH2, 6, MLH1. You must be knowing all these terms. Single strand DNA damage is also being taken care by nucleoside excision repair, and then single strand break repair, and here the PARP1 comes into play. So these are the ways in which the single strand DNA damage is being repaired. Double strand DNA is repaired by homologous and non-homologous end joining, and homologous recombination, here comes the BRCA1 and BRCA2. What happens? See here, this is a DNA. Single strand is damaged. PARP comes, it binds to the DNA. It also attracts many cofactors, and all of them, they work together, they fix it up, and they leave. Now PARP modifies itself and detaches, and now the repair is complete, and this is a normal DNA. But what happens when PARP inhibitor comes into play? PARP inhibitor inhibits this part. Now PARP is not able to detach itself. It inhibits the modification of PARP. The and PARP is not able to detach itself. So DNA repair is hampered. So here is here is the activity of mechanism of action of PARP inhibitor. Now double strand DNA. I have shown you that there is one homologous recombination repair pathway, and there is non-homologous end joining repair pathway. What are these? Here you can see this is a DNA. The double strand of the DNA, it is damaged. Now what happens? BRCA1, which is a repair gene. So whenever there is a damage, this MRE11, it comes into play. It eats up whatever, it resects whatever bad genes are there, so that it is now a denuded DNA, which is even. Now when MRE11 does its job, BRCA2, it recruits RAD51, PALB2, and all they repair, all of these combine together and they repair, and this repair is a original one. What BRCA1 does? BRCA1 blocks this 53BP1. It is bit complicated actually. When you will go through, when you will read this pathways more often, you will be able to understand, you will be able to go mug it up that what is actually happening. BRCA1 inhibits 53BP1. When 53BP1 is not being inhibited, it does not allows this MRE11 to work. So whenever there is BRCA1 mutation, so there is no one to block 53BP1, and what it will do, it will inhibit MRE11, and MRE11 is not able to work. In that case, the repair pathway is not happening, and there is carcinogenesis. Similarly, in non-homologous means there is no BRCA pathways in this thing. 53BP1, it does its work itself. It chews the ends of this DNA, and there are many deletions, and the repair is introduced, but with deletions. So this is a kind of repair. It is an uneven repair, but then yes, it is a kind of repair in the cell. Now, what happens when we give PARP inhibitor? This is a normal cell. Single strand DNA and double strand DNA repair is happening properly. Cell is viable. Now, the normal cells, you give PARP inhibitor, single strand break repair, it is not happening, but double strand, the single strand will convert into double strand, and then double strand repair pathway, it is happening normally, so cell will be alive. If this HRR deficient, this homologous recombination deficient, that is BRCA1, BRCA2, PALB2, RED51, any of these is deficient, in that case double strand break repairs is not happening, the repair is not happening, but yes, single strand break repair is happening, so cell will remain viable, though it will be a cancerous cell. But then if you give PARP inhibitor, then in that case single strand repair is not happening, double strand repair is not happening, and this HRR deficient cell, which is making a cancerous cell, it will die. So that's how this PARP inhibitor works in a patients who are having BRCA1 and BRCA2 mutation. So how you test BRCA1, BRCA2? If you want to test genes, genetic BRCA1, BRCA2 mutation, then in that case you use saliva, blood, then Buffy code, buccal smear, because these mutation will be there in each and every cell of the body. So by this you can test germline, BRCA1, BRCA2 ATM check mutations. So these are the PARP inhibitors. We have veliparib, olaparib, rucaparib, niraparib, pemiparib, and talazoparib. And yes, how to decide which drug to give, which PARP inhibitor to give? Again, it is side effects. Side effects, we can see that the patients who are getting talazoparib, there is more of a neutropenia, there is more of a thrombocytopenia. While the patients who are getting olaparib, rucaparib, they are having nausea, vomiting, diarrhea. But yes, olaparib is the drug which is usually more tolerable. Niraparib, it causes lot of nausea, lot of vomiting, and lot of thrombocytopenia. So niraparib is a difficult drug to manage, whereas olaparib, this is a drug which we are able to manage better. Rucaparib has taken lot of role now, because rucaparib is the only generic PARP inhibitor which is available and cheaper than olaparib. Olaparib costs 5 lakhs per month, while rucaparib, it is almost 60-70,000 rupees per month. Coming to the studies, the patients who are having deleterious germline BRCA mutation, if they have received chemotherapy previously, less than 2 previous lines of chemotherapy, they were randomized to receive either olaparib or chemotherapy. Now that was a physician's choice. The drug they have received was capecitabine, vinorelbine, eribulin, because these patients have already received taxane and anthracycline. And we can see that it has shown progression-free survival benefit. It was 7 months versus 4.2 months. But then overall survival benefit was not there. So PARP inhibitors, any of the PARP inhibitors had not shown any survival benefit. So whenever we give this drug, we tell the patient, yes, it is showing. If the patient is like, I just want to take oral pill, I don't want to take any injectable chemotherapy, this kind of patients, yes, you can advise and you can tell them that it has shown progression-free survival but not oral survival. Now, if you give olaparib in the patients before chemotherapy. So chemotherapy naive patient, yes, it has shown overall survival benefit, but not in the patients who have received chemotherapy. Adverse effect, as we can see that when it was compared with the other drugs, nausea was higher, anemia was higher in this drug, and vomiting, nausea and vomiting was higher, and anemia was higher. Otherwise, neutropenia was higher in the patients who receive chemotherapy. Similarly, when grade 3, grade 4 side effects were compared, anemia was the thing which was there more in the olaparib arm, while neutropenia and other side effects were more in the patients who were getting chemotherapy as expected. Now, EMBRACA study, that is talazoparib, here also the inclusion criteria were same, and talazoparib also it has shown progression-free survival benefit 8.6 months versus 5.6 months, but yes, it has also not shown an overall survival benefit. So safety profile we have already seen, and both the studies they have shown that the patient who are hormone negative, triple negative basically, they have shown benefit, but the patient who are having HR positive and BRCA mutation, in that case they have not shown that much benefit with the PARP inhibitors. If the patient has not received platinum previously, then also it has shown benefit, PARP inhibitors, but if the patient has received platinum compound, in that case it has not shown that much benefit. And we have compared the side effect profiles, and we know that niraparib and talazoparib are difficult drug in terms of thrombocytopenia, anemia and neutropenia, as well as fatigue. But yes, PARP inhibitors, whenever we prescribe PARP inhibitors, we should also tell the patient that there are chances, 2% chance that they may develop secondary malignancy, secondary hematological malignancies like AML, MDS. We have published our data. When I was at BL Kapoor Hospital, we have published 20 patients or 26 patients when olaparib was not launched in India, and we gave 26 patients on a compassionate program, and 4 of our patients, they do develop AML or MDS. In fact, they were in preface smear it was showing AML, and once we stopped the drug, everything got vanished, and that was also a case report from our side. Coming to the immunotherapy in TNBCs, so and that is Keynote 355, in which pembrolizumab was combined with chemotherapy in a patients who were previously untreated metastatic TNBCs. So they received pembrolizumab Q3 weekly plus chemotherapy, and which was compared with chemotherapy alone. And here we can see that it has shown or survival benefit in the patients where PDL1 is more than 10%, CPS score is more than 10. It has shown a trend towards OS benefit in a patient who are having CPS score more than 1. So first, in a TNBC patient, we check this PDL1 status. If it is positive, in that case we can advise pembro plus chemotherapy combination. But if it is negative, in that case it has not shown any benefit. So it has shown PFS benefit, it has shown OS benefit. Side effect profile, it is not much different, but yes, immune related side effect profile is there, and though it is less, almost 5 to 10% only. So they have concluded in Keynote 055 Keynote 355 that there is OS benefit, there is PFS benefit, and the patient who are having CPS score more than 10, they should avail this chemotherapy and immunotherapy combination. And the patient who are having CPS score more than 1, they can also get this drug. Coming to HER2 positive breast cancers, and there are numerous targeted therapies in that. We know trastuzumab, inhibitor of HER2, margetuximab, and these are HER2 targeted monoclonal antibodies. Pertuzumab, which inhibits the dimerization. We know lapatinib, niratinib, tucatinib, these are the TKIs, mTOR inhibitors, which we have already seen in our previous cartoon. Now there is one entity, that is HER2 targeted antibody drug conjugate. and they are TDM1, then trastuzumab deruxtecan, trastuzumab dacarbazine. So we will go through the mechanism of action of HER2 targeted drug antibody conjugate separately. So for metastatic or recurrent cancer, trastuzumab, pertuzumab and taxane combination is the preferred choice. And Cleopatra trial, that is the trial which has made the place of the combination trastuzumab, pertuzumab and docetaxel, and it has shown an overall survival benefit, that is 17 months. Have we ever thought that at 8 years 37%, almost one third of the person alive of metastatic HER2 positive breast cancer? But now, yes, it is possible now. When TDM1 was also being tried, TDM1, we know that this is the drug which is being used in second line, and the best part is that we have generic TDM1 now. So people have tried this TDM1 using in the first line, but it has not shown any benefit. So there's no point of using a costly drug upfrontly. But then, who are the patients in which you can use TDM1? First thing, as such, the patients who don't want alopecia. Here you can see, because of taxane, 60% of the patient they will be having alopecia, while it is 7.2% of the patient. Rest of the side effects, they are usually more in the combination while less in the TDM1. But yes, TDM1 will cause rise in AST ALT. So this is the only indication when we can use TDM1 in the first line setting. Now when we compare TDM1 with other combination, lapatinib and capecitabine, in the second line setting, then yes, TDM1 has shown overall survival benefit. Or when it is compared in the Theresa study, there also, when it was compared with the physician's choice, it has shown overall survival benefit. So first line, if money is not an issue, in that case we advise trastuzumab, pertuzumab and docetaxel or paclitaxel in the first line setting. Second line setting, TDM1. If the patient is not affording, then lapatinib and capecitabine combination is good enough. And now, what is the side effect profile? So lapatinib and capecitabine, they have almost similar side effect: hand-foot syndrome, diarrhea. So that's why grade 3, grade 4 diarrhea is so much. All grades it is 80%, grade 3, grade 4 diarrhea is almost 20% of the patients, and hand-foot syndrome is also there, is very common. While TDM1, the side effect profile is quite less. But yes, if you give TDM1, then AST ALT rise is an issue. Then coming to the drugs which can be used in the patient who is having HER2 positive CNS metastasis. In that case, lapatinib capecitabine combination is there. Niratinib capecitabine combination is also there, but we don't have niratinib in India. Then trastuzumab, capecitabine and tucatinib. This combination is the best combination when it comes to patient with CNS disease. It has shown the maximum overall response rate, but tucatinib is not available in India. Rest of the drugs, TDM1, trastuzumab, pertuzumab, they don't cross CNS barrier. So what are the HER2 targeted agents? That is one is niratinib, tucatinib. HER2 antibody drug conjugate is trastuzumab, deruxtecan, trastuzumab, dacarbazine. Now niratinib plus capecitabine combination was compared with lapatinib and capecitabine combination in second line and beyond. Then in that case, it has shown PFS benefit but not OS benefit. So you don't have to push the patient for niratinib because it has not shown OS benefit as such. It's just 24 months versus 22 months. But yes, niratinib, it has better CNS penetration, better response rates in CNS. So the time to intervention for CNS metastasis is longer in the patient who have received niratinib. The side effect profile. Niratinib is also a difficult drug to manage. The diarrhea, you can see 1/4 of the patient they will be having grade 3, grade 4 diarrhea. And rest of the side effect profile is almost similar to that of the lapatinib. Coming to tucatinib. Tucatinib is a magical drug, but yes, we don't have it in India right now. So tucatinib, it does not have EGFR activity. So when it does not act towards EGFR, that means it will not cause the side effect which is caused by the TKIs. CNS penetration is highest, and here you can see that how much, if we want 8, this is a quantity, if we want 8 molecule of niratinib to cause the side effect, tucatinib we want 4000 of the molecule of that to cause that kind of side effect. So that means EGFR activity is so less with tucatinib. So HERCLIMB study, here trastuzumab capecitabine has been combined with tucatinib, and it is compared with trastuzumab and capecitabine combination. And here we can see the amazing interesting fact that 50% of the patient, they had CNS metastasis. We can see that the patient who received tucatinib, they had significantly better progression-free survival. They had significantly better overall survival as well. The CNS metastasis, the patient who had CNS metastasis, they also did well. The patient, all overall survival, the progression-free survival in the brain is also better in the patient who received tucatinib. So tucatinib has been approved, and it is given 300 milligram twice daily with or without food. And when it is, there is the issue with tucatinib is hepatic impairment. Plus tucatinib also causes diarrhea. I don't know how, but then it causes severe diarrhea. So there is a point where we have to reduce the dosing of tucatinib. We have to adjust it. Then coming to drug antibody conjugate. So here with this you can see that this is an antibody. We have seen this kind of cartoon multiple times. This is tumor antigen. And what is this? This is a linker. And now what is this? This is the cytotoxic drug payload. So this is the drug, this is the linker, and this is the antibody. So what do we want? We want an antibody which gets attached to this tumor antigen. We want this linker to be strong. We want this drug to be strong, to as a good cytotoxic drug. So what happens? This is HER2 drug antibody conjugate. It gets attached to HER2 because this is anti-HER2. Now this is HER2, so it gets attached. Now with the help of endocytosis, this drug antibody conjugate goes to the cell plasma. Now when this is inside the cell, this linker, the linker, it gets dissolved, and the drug is then released inside the cell. Now here is the time when the drug actually works. It kills the cell. Now what is bystander killing effect? Sometimes the drug, because this membrane is big or the drug is small, it comes out because of the permeability of the cell membrane. While sometimes there are certain cells which are the linker is not strong, and the cell is and the cytotoxic drug is released outside the cell. In that case, it will act to the nearby cells, and this will lead to lot of side effects as well as decreased activity of this drug antibody conjugate. When this drug antibody conjugate, when there is lot of drug attached to this antibody, in that case, even if it is HER2 1+, then also this will act. So that's why the newer compounds which are coming up, they are being tried in even in low HER2 positive tumors, and they are actually working. So early generation, it was mouse antibodies, it was immunogenic, unstable in circulation, and unstable to release cytotoxic drug within the tumor cells. That payload chemotherapy was doxorubicin, Venca alkaloids, but now it is either chimeric or humanized antibodies with reduced immunogenicity, stable in circulation, and the linker is disulfide dipeptide bond, and the cytotoxic payload are different now. So in trastuzumab deruxtecan, this is the picture. It is almost like each and every drug antibody conjugate, there is some difference. The high drug antibody ratio, because in that case it is 8. That means it can work in the patients who are having low HER2 expression. Stable linker payload, so that's why it is not released outside the cell. It is released only inside the cell. Tumor selectable cleavage linker, high potency membrane permeable payload with short systemic half-life, and then the bystander killing effect is quite less with trastuzumab deruxtecan. So this drug is amazing actually. So in the study, her Destiny Breast 01 study, you can see the patients, the median number of prior cycle was 6. So prior lines of treatment was 6, and these all the patients, they have received trastuzumab, they have received TDM1, 65% of them received pertuzumab, and even in that, these patients have shown an oral response rate of 61%. The patients, can you imagine the patient who have received 6 lines of treatment and now achieving CR with trastuzumab deruxtecan, partial response of 55%. It has shown progression-free survival of 16.4 months, and median overall survival is yet not reached with the follow-up of 11 months. Side effect profile, it is mainly nausea, vomiting, fatigue, and constipation. The important fact with this drug is interstitial lung disease, and here you can see that 13 to 14% of the patient, they develop interstitial lung disease, and that part is difficult to manage. And what is recommended is that if you suspect interstitial lung disease, first of all, if a patient who is asthmatic, who is a COPD patient, you will not advise this drug. And if a normal patient develops it, you will stop the drug, do the CT scan, consult a pulmonologist, do other investigations to rule out if there is a secondary infections, and then hold the drug. If the interstitial lung disease, it gets resolved within 28 days, you can restart the drug with the same dose. But if it takes more than 28 days, reduce one level. But if it takes more than that, and if it is not resolved in 49 days, grade 1 ILD, I am talking about grade 1 ILD, you will not restart this drug. And if a patient develops grade 2 or beyond ILD, in that case you will never advise this drug. So this is how you manage, because there's no point of going through this, the way to manage ILDs. But yes, you'll have to be cautious about interstitial lung disease whenever we advise trastuzumab deruxtecan. So the dose is 5.4 milligram per kg Q3 weekly, and CBC should be done prior administration. SSLVF 2D echo should be done, and you will do PFTs as well, monitor for ILDs and pneumonitis. So in HER2 positive, first line is trastuzumab, pertuzumab, taxane. Second line is TDM1. Third line, we have already discussed all the combinations of this drug. So targeted therapies, we know that if it is hormone positive, CDK4/6 inhibitors is there, PIK3 inhibitors are there, mTOR inhibitors are there. HER2 we have discussed at length, monoclonal antibodies, TNBCs, PARP inhibitors, immunotherapies. Thank you.
Thank you, Dr. Sphalta. It's a wonderful lecture. And the way you talked about the pathways, it was very easy to understand.
Oh, great.
Yes, yes, because it is really very difficult. but the way you taught the students is a nice presentation. I have one question. Like you told, tucatinib, it's not available in India, but it works very well in CNS tumors. In CNS spread of breast cancer patients. Usually, breast cancer patients having metastasis at a multiple sites. But you are saying in hepatic impairment, it's difficult to give this drug. So I just, as a radiation oncologist, I'm not a medical oncologist. So I just want to ask, like, if our patient is having hepatic metastasis and with the CNS metastasis, with any other drug which is available in India, so should we give it or not, and what will be our criteria before giving those type of drugs?
See, first thing is it may cause severe hepatic impairment, but it is not contraindicated in a patient who are having liver metastasis. So, what we do is we advise it with trastuzumab, tucatinib. It will work in whole of the body. It will work on the liver as well when the liver metastasis is there, and subsequently, liver function will improve. The side effect of tucatinib, if the patient is having so much of metastasis that the liver impairment is already there, then you cannot use this drug. In that case, only trastuzumab or pertuzumab are the drugs which you can use in the patients who are having hepatic impairment. So it is like you have to monitor it. A patient who is having liver metastasis, you give you give tucatinib. The disease is responding, the patient will feel better. It is not that the hepatic impairment is going to happen to all the patient, but yes, you will see that patient is responding, but then liver enzymes is deranging. In that case, you will have to reduce the dose of tucatinib, you will have to give a break and continue rest of the medications. That's how it is managed. It is very difficult. It is like weekly we'll have to see in this kind.
And in our chat box, we have one question by Sunita Prabhakar.
Okay.
If ER/PR positive and HER2 positive, can we combine estrogen antagonist with HER2 inhibitors, or is HER2 inhibitor is used with chemotherapy only? Should I read it again? It's clear to you.
Yes.
Okay.
So actually, when you go through the mechanism of all these cancers, you see when the patient is having HER2 positivity, that case that is the driver one. So what happens is that even if you do if you give CDK4/6 or something like that, it will not work. It will, the HER2 is the one which is actually working on it. So what we do is we give chemotherapy and trastuzumab and anti-HER2. It is not like we give combination of hormone plus anti-HER2. It is not like that, because the driver is HER2 here.
Okay. And second question, if metastasis happen years later after HER2 treatment, can we re-challenge with Herceptin?
Yes, in fact, in one of the study we have shown that the patient who are on trastuzumab and not able to tolerate lapatinib, in that case we can continue trastuzumab even if the patient has progressed on it, and we change the chemotherapy drug. So actually, whenever a patient progresses, what we advise is that to re-biopsy it, because there are certain mutations which has happened. Like there are patients who were HER2 positive, but then now this HER2 is not no more working now, and you do the biopsy and you find that there is no HER2 positivity now. It is either triple negative, or it is like hormone positivity is there, which is rare. Usually what we see is triple negativity. In that case, there is no point of giving trastuzumab in this patient. So you should re-biopsy it, and yes, if it comes out to be HER2 positivity, Herceptin can be re-challenged.
Thank you, Dr. Sphalta. Now, I request Dr. Shalin sir, please give your valuable suggestion or hello, Shalin sir is there?
I'm very much there. I'm trying
Yes,
to, I don't know, for some reason my video is not coming on. So it says that the host has stopped my video. So that's okay. Doesn't matter. First of all, thank you very much, Dr. Sphalta, for educating, a bunch of radiation oncologists in the making. And I have to say that I did join a bit late, so I missed the initial part of your presentation. But all I'll say is thank you very much for joining in, and I'm sure there's a lot of information to take in and for people to digest. These things, merely learning the names is not enough. One has to obviously understand the pathways for a rational combination.
Yes.
And the second skill that is required from radiation oncologists would be that they have to have a grip on medicine, if they are to take, if they're also to, navigate the patient safely. You see, giving, you give tamoxifen, you give anastrozole, you give, aromatase inhibitors, you give other things. That's one thing. When you go down areas which are, affecting liver function and cardiac function and so on and so forth, and then understanding the physiology of liver function and the pathophysiology and what happens to the heart function, derangements, etc., and whatever else. One has to have a grip on it to be able to navigate safely. And I hope this is an incentive for the radiation oncology colleagues and students to understand that medicine is basic graduate level medicine is important to navigate your patients safely, whether or not these drugs are given, but certainly if you wish to give these drugs beyond the usual cytotoxic chemotherapy, which is relatively more predictable and is better understood. And for these, one has to understand molecular biology and genetics and other things to a greater detail, I assume. But I let you have the final comments and others also. Thank you very much for coming in.
Thank you, sir.
I have one question. Can Herceptin be given along with radiation?
I'm not able to hear you, please.
Yeah, Tanjumat can be given along with radiation. Can you hear me?
Please, can someone else convey me the question, please?
Yes, the question is, can Herceptin be given along with radiation?
Herceptin, yes, it can be given along with radiation. In fact, Herceptin is like post-operatively, pre-operatively, first day, second day, we give Herceptin. So there is no contraindication as such. With radiation, we don't give tamoxifen because it increases interstitial lung disease chances. Otherwise, if letrozole or AI is advised, then it can be given along with radiation.
Rashi, you want to say something or any question from your side?
Nothing, ma'am. Dr. Sphalta, you have presented very well, and I think for radiation oncologist, you have done a good job, and in simple words, you have explained us things. Thank you so much. Although Dr. Sphalta is with me, so many questions are there. I often discuss with her on phone. Thank you so much, Dr. Subhi. Over to you, and thank you so much.
Dr. Sphalta, once again from Up-Aroi side, thank you so much for giving such a wonderful talk on this very complicated topic. Thank you, Dr. Marisha, for moderation of the session. Thank you, Dr. Salim sir. Thank you, Dr. Rashi. And thank you all.
Thank you.